So, merry afternoon to you all. We've just had our afternoon tea break and now we're really ready to claim that table and have a nice afternoon snooze, huh? Well, you're in the wrong place. We're going to do stuff. How many of you here have actually had some level of experience with mobilisation techniques of some form or another? Just a show of hands. Great. How many have not had any experience whatsoever? Oh, great, fresh meat. Beautiful. So today is going to be an extremely condensed version of the field, the discipline of mobilisation, manipulation, manual therapies. We have 40 minutes or so, and my key aim today is that you leave here with something practical and useful to do and apply to your clients when you're back in clinic, whether it be tomorrow or next Monday. In order to just give some context, we're going to need to cover a few details. Now I'm going to be walking backwards and forwards. I don't have a remote control. I do have a remote control, but it just doesn't do anything. So I will have to go forward and let you know, giving some background. Manual therapies, the field of manual therapeutic practice is something that I've specialised in now exclusively for nearly 20 years. It's a field of our profession that really intrigues me, excites me, and I get very enthused about the work, and still to this day. It all stemmed though from an incredible sense of frustration. Because what happened early on in my practical career as a podiatrist was, for musculoskeletal conditions, we are taught through our undergraduate training how to control, treat, manage those conditions through the use of orthotic therapy. That's our primary form of treatment methodology. And the number of times I would have women in particular complain to me. This is in a professional sense, not in a personal sense. So I just want to make that clear. But we provide beautiful orthotic devices, and knowing that they were going to provide great therapeutic value. But the time and time I was asked, isn't there something else? Isn't there another way that we can actually treat or deal with this? And why is that? Why not use orthotic therapy for all of our biomechanical cases? Women? You better answer that. Are you going to be able to fit them into those shoes? So, as far as utilising orthotic therapy and to control mechanical compensations, absolutely a perfectly valid thing to do. But this is a site that we see reasonably commonly at the Foot and Leg Centre, where people have had a range of orthotic devices, and Gunther himself just literally threw these down on the desk and said, "So which ones should I be wearing? Are any of them, which ones work best for you?" Well, none of them work. It's like, I don't have a solution for my problem. So the field of manual therapies is really about providing another treatment option. But what we're going to cover today is literally to incorporate it with your existing biomechanical orthotic therapy-based treatment plan. So I don't want you to throw out the baby with the bathwater or anything like that. Really want to show you a couple of techniques that help make your orthotic therapy more effective. Now, the physiological premises that we're going to be working with is manual therapies is essentially a marriage, and it's a marriage between the podiatric biomechanical understanding that we have as podiatrists and combining it with the skills and techniques that the manual therapy professions like physiotherapy, osteopathy, chiropractic, what they do. Those professions are based on the use of manual therapeutic techniques. And what has happened over the last 20 or so years is basically I've combined the biomechanical understanding that we have with the manual therapeutic methodology that the other professions use. The fact is, no one knows a podiatrist like no one knows a foot like a podiatrist. Because no one knows a podiatrist like a foot, huh? The number of times I get asked, well, what is this work? Where did you learn it? It looks like physiotherapy techniques. And it is. Oh, so you mean my physio could do this? Technically, they could. but they don't know the foot like we know the foot. So we need to claim that, make sure that that's our domain, and have the expertise to be able to provide a range of services so that we can basically claim and help more people. That's really why I got into this field, because I knew there were people that I was unable to help without these skills. So, physiological principles of manual therapies. First one is, how many of you here have ever experienced or know of someone in the world who has experienced a broken arm? Show of hands? Great. So, here it is. Someone has a fractured arm, surgical correction takes place, the arm gets immobilized in plaster. For how long? Typically, how long does the plaster stay on for? 6 weeks. It's about how long it takes the bone to heal. Plaster's then removed. Once that plaster is removed and all the tissues have healed, can that patient then automatically use their arm through a full range of motion? No. Why not?
Because all the muscles atrophy for a start, and they haven't been using appropriate receptors, lose their sort of off kilter,
Yes.
and everything withers and wastes away, and you've got no strength and stuff.
That's certainly what happens to the muscles. The other connective tissues, ligaments, joint capsule, they all do one thing absolutely every time, in every body, every second of every day. This principle you must understand and appreciate, and I'm going to make sure you do, so I'm going to tell you this principle, and then what you're going to do is just repeat it back to me so I know that there's no misunderstanding. The principle is this: connective tissues always adapt to their shortest functional length. What do? Always adapt to the shortest functional length. Okay, this time as if you almost might mean it. What do? They always adapt to the shortest functional length. It's just the facts. It's the basis, the physiological basis behind use it or lose it. If you don't use the joint through its full range of motion, connective tissues adapt. They contract on the medial side, extend on the lateral side. You get the connective tissues adapting to that position. So then what happens with this person is they need to have some physiotherapy, some stretching, some exercises, and then over time, you open up those connective tissue restrictions and the full range of motion is restored. Make sense? Yeah. It's not rocket surgery. It's pretty much as basic as the fundamental as that. What happens with the foot is exactly the same thing, except we have a lot more connective tissues, ligaments, capsules, tendons, not so much the muscles. Muscles adapt pretty quickly, but the connective tissues that hold bones together, they take a longer period of time because they're tougher and more plastic in nature. Now, we don't have the time this morning, this afternoon or tonight to go through each of the reasons why these are contraindications for foot mobilization techniques. So at this point, the question is there anyone here in this room that has any of these aspects? Great, which one can I ask?
Stress fracture of the tail of RSD plus submuscular of the knee, lateral flexion compound.
Too many syllables for me. So you can be a practitioner, don't let anyone work on it. Great, so you be a practitioner. Anyone else? Anyone here in a hypermobile category? Maybe? Okay, be a practitioner. So the thing about mobilization techniques, they increase joint mobility. If you're hypermobile, the last thing you need is more mobility, you need stability. So that's where it's contraindicated.
Tim, why is it contraindicated with stress fractures? I know you're on a lot of time thing out here, but I find when you're not mobile, everything you get osteoporosis as well, everything shortens your muscles, and it took me about 6 months just to straighten my leg. So so why is it contraindicated with stress fractures?
Because one of my mentors said, the most important thing you can do is not create. Oh, okay, so this is suspected acute stress fracture. Yeah. That's the distinction here, as distinct from one that's already healed. But what's really important, either a stress fracture or a suspected fracture, Harvey, one of my original mentors, said, don't create a joint where there's not supposed to be a joint. So if you have any of the clinical signs of these happening here, you don't work on those areas. Okay, so let us rock and roll. We have picked on the fibula today because of its amazing fascial interconnections through the whole body. If you want to Google anatomy trains and just see the incredible recent research that's going into the understanding of how the body works in a network fascial manner, a really interesting area. If we focus on the lateral line, you'll see the fascial connections from the base of the fibula up through the perineals, through the ITB, right through the lateral structures, right up to the skull. There is a direct, tangible connection between fibula and your skull. So what I'm going to show you today are techniques on how we can release any connective tissue restrictions around the fibula so that we can get a better clinical outcome for some of those lateral compartment conditions. Biomechanically, we need to be aware of a number of factors. First of all, in the classical subtalar joint hyperpronation pattern, what does the talus do? Imagine leg, foot, talus inside the ankle. When the foot pronates excessively, which direction does the talus go in? AB ducts? You sure? AD ducts. So talus typically shifts forward or inwards or plantarly. So it shifts forwards and inwards if it was on the right side. Does that make sense? Okay, good. What direction does the leg go in? So if we've got the talus shifting anterior or anteromedially, what's the leg going to do? Is it going to rotate medially, or you call it internally, but that's technically accurate, not accurate, but anyway, I won't pick on you for that. So it rotates medially towards the midline. That's the direction of the leg, which is in response to the talus rotating in that direction. Fibula. What direction does the fibula go in when we rotate the leg medially or internally? Well, it kind of just goes all along the way, doesn't it? Because it's all attached. It kind of does, but you know what? It doesn't. Because of the fibular attachments proximally positioned. Which muscles, tendons, attach into the head of the fibula? Biceps. So hamstrings on the outside. What else? Perineals as well. Great. ITB. Okay. If any part of the body shifts or displaces away from its optimum position, the body tries to correct that. If the body is going to try and correct or move a joint or a bone, what is it going to use to try and pull a bone in the right position?
Capsules, joint capsules, ligaments.
Okay, can those structures contract and make a bone move? No. Muscles. The body uses muscles to pull things back into position. So, imagine this. You've got a patient that's doing an excessive pronation pattern through the subtalar joint, resulting in internal or medial rotation of the leg. Body's going, not good. I'm going to use muscles to try and straighten the leg up. The muscles that it's going to use are the ones that cause external or lateral rotation. Now we've got some hip rotators that will do that, and the gluteal muscles. But on the leg itself, you've got the biceps femoris, the hamstrings, literally trying to pull the leg into an external rotation. Does that make sense? If they're attached into the fibula, what's going to happen to the fibula? It's going to get pulled which direction? Posteriorly. Now, if it continues to be pulled in a posterior direction, and that force is maintained consistently every step that that patient takes, what's going to happen over time? What are the connective tissues going to do? They're going to adapt to their shortest functional length, which means posteriorly, if the fibula shifts posteriorly, the connective tissues are going to adapt to that, because that's where they're being held and pulled. Make sense? Okay. The fibula needs to move. Proximal and distal, it needs to be able to glide to allow for ankle dorsiflexion motion. It's not a fixed structure like the tibia. So what we're going to do first of all is check to see if our fibula, it's plural. If those bones on the outside of the leg do actually move, proximal and distal. The technique we use to assess whether they move or not is the same technique that we use to actually mobilize those joints. So it's both a assessment technique and a treatment technique. Okay. Any questions at this stage? Anything I've covered so far? Make sense? Cool. Pretty fundamental. The way we talk to our clients is pretty much in the terms of, if things are a bit stuck, we're just going to free them up to move them closer to more how nature intended them to work in the first place. That's what we're going to do today with your fibulas. Now, is there anyone here who has a recent history of perineal, ITB, knee troubles? Are you willing to volunteer?
All right, yeah.
All right, come on up and let's find out. One side, both sides?
Mainly the left.
Mainly left, all right, we'll do that. I'm going for it. You willing to tell the audience that we've never met before? Simon, great. Thanks for volunteering, Simon. Well, I don't know if you really did volunteer, but you've taught people. Shoes and socks off, both feet, please. Great. Okay, so left side. What I'm going to ask you in just a moment to do is we'll have you sitting on the plinth here. But here is essentially the technique that we're going to, oh, thank you.
Left one needs it too.
Thank you. Okay. So whenever we apply a mobilization force to a joint, we need to stabilize the surrounding joints and focus specifically on the joint that we're going to mobilize. Concentrates the force on the specific joint that we're targeting. So what's happening here is I'm just stabilizing the foot against the table, which we'll do here, or you can actually have the foot sitting at 90 degrees and stabilize by placing your hand over the foot. I'll show you both methods. What's important here though is to have the knee flexed. Why? Why should we have the knee flexed? Exactly. So if the knee is extended, the tension, tissue tension through the ITB and the lateral structures, perineals and hamstrings is increased, and it's hard to gauge, hard to get an isolated movement in the joint. So we'll stabilize here, and then literally contact point. Your contact points are the widest part of the lateral malleolus. So just feel with your thumb, where does it stick out the most? And the finger, where does it stick out the most? And that's where you hold on. I would suggest for those of you who don't have massive forearm flexors, use 2 fingers. Grab around the 2 fingers and here, because it takes a reasonable amount of force. Great. So what I'm going to need you to do, if you sit this way, and yeah, just to wake up. Any history of ankle sprains?
Not a bit. Previously.
You haven't ruptured any
No.
ligaments or anything? Okay, great. So just hold the foot there. So what I'm going to do is I'm just going to palpate. I can feel the lateral malleolus most sticking out furthest, most prominent anteriorly, and then posteriorly, and I've got it. Now, with a mobilization technique, you need to apply force and let the tissues respond to the force. So what that means is you're going to kind of push 2, 3, pull 2, 3. It's about that speed of movement. Typically it matches up with your breathing. If you're like me at the moment, it's going to go. So, into position, I'm stabilizing the foot here so that the ankle's not moving or it's not inverting. Once I'm here, then I'm going to push 2, 3, pull 2. Okay, good, we've got some movement here. In a normal fibula, the fibula will typically move about 4 to 5 millimeters. So that's 4-5, not 45 millimeters, because then you have another problem going on. Or just about more past mine. That's okay, you will be. All right. So we're going to grab hold of the fibula here, and it's a push, 2, 3, pull, 2, 3. Tips for new players. The important thing here, when you push, the natural tendency is for you to remove any resistance and take your fingers away so that you can really push with force and there'll be nothing or less resistance. If you do that, you won't feel the body of the fibula base actually moving. In fingertips are very sensitive, and you want to feel if it's actually moving posteriorly and anteriorly. So you'll have to consciously hold on to the fibula, get your fingers into that position like a claw, wrap around there, and then push. Nice. Okay. Can you feel that moving?
Yeah.
Yeah. Gross, isn't it?
A long way.
Yes. I'm a bit worried. Okay, good. So, do you recall though when I first started moving, it wasn't kind of moving? So it took about 3 repetitions to actually get some movement happening. If you find, and I know there are some of you here, sorry, I was just looking for Concrete Man from the other night. He's not here today, but God, he was like concrete in his joints. Some joints will move really easily, and if they move easily, it's great, I don't have any restriction. But if you, typically you'll do 3 repetitions, posteriorly and anteriorly, and you'll generally notice that the range of movement increases by about the 3rd repetition. If it's still really restricted, do another 3 repetitions. At a maximum of 6 repetitions. If it's not moving after 6, stop, because then you'll start causing irritations. But generally, as we found here, about 3 repetitions, posteriorly and anteriorly, and things started to loosen up. Can you remember all those points? Keep your fingers, thumbs in position, stabilize the area, focus on that movement, go up breathing speed. Oh, better still, got all that. Up here. Great. So, I talk in terms of medial hand stabilizes, lateral hand creates the movement, because when you swap legs, then medial hand, lateral hand swap around. Medial hand, medial to the patient, so medial to his midline of the body. In this position, in this picture is my right hand, lateral hand away from the midline is my left hand here. So, the way I'm going to recommend you do this is buddy up, pair up with someone, and then literally have, do you want to? Hannah, can you slip off one shoe for me, please? Just as a demonstration, you can slide it up here, and then as a practitioner, you can just get yourself into position and then try that mobilisation. So we've got enough chairs for everyone, just might have to sort of rearrange the room a bit too. So practitioner and patient, and then swap over.
We can try all that.
So is that gonna? Yeah. Maybe that'll be another one. still running on that Michael? Of course you're still running.
Well, I want to go into the surgery for the fit, so that means the recovery can be less. It's always the big, you always think.
Alrighty, boys and girls. Just find a place to sit yourself down at the moment, because you're only going to be there for 2 minutes, and then we'll get back into more hands-on stuff. Any observations? Anything you noticed? Any surprises? There were a couple of screens. Everyone can still walk? Ish? Alright. So then we are going to tackle the proximal part of this bone, the head of the fibula. Now, just be aware, again, for the same reasons why we want to keep the tissue tension out of the anatomical structures that are connected into the fibula, make sure the knee is flexed. If the knee is not flexed, what happens is you'll fight against the long axis tension that goes through the hamstrings and the ITB. So flex the knee and then stabilize the tibia with your medial hand and then generate the force with your lateral hand. The thing to be aware of here is to get hold of the head of the fibula, your fingers actually have to wrap around surprisingly far in the posterior aspect. And what structure do we have running around behind the neck of the fibula? Perineal nerve. So if you get the nerve and the leg flicks out and hits you in the jaw, you found the nerve. Move your fingers. So just watch out for the perineal nerve. And generally you'll feel like a shoelace underneath the skin there if you're on it. If you're on it, move your finger away so you've got bone-on-bone contact. Bone on the finger, bone on the fibula. Great, Chris, let me just demonstrate that with you as well. So if you go into the same positions here. Now, those of you who are wearing jeans, you can just palpate through the jeans. You can, but if that's... pull them down. I mean, just pull it. And lift that knee. So, yes, typically I would still palpate the head of the fibula. And then, tips for new players. Generally, the most common thing people do is try and sort of grab hold and pinch it on the outside. You won't get good grasp of the fibula. So you need to slide your finger right around. You'll see that the end of your finger literally disappears behind the knee. And then there's a lot of flesh. You've got the gastrocs, the head of the gastrocs here. You kind of have to navigate your way and squish in between the fibers so you get hold of the fibula. I then use my middle finger to reinforce my index finger, stabilizing the tibia with the medial hand, and then pull. So just flicked on the perineal nerve there. So I am in a very vulnerable position. Okay, so now I trust myself. Okay, great. So it's a pull, 2, 3. Oh, okay, so now you go posteriorly, really easy, there's no resistance there. However, coming in this way, a lot of resistance. Bellissimo. You're a pronator? Yeah, okay, so this is what's happening here with Chris. Simon, when is she Okay, so the leg, your middle name's Chris, isn't it?
No middle name.
Okay. So when the leg rotates in that internal or medial direction and the hamstrings constantly pull posteriorly, there's very little resistance with Simon to push the fibula posteriorly, because that's what it's used to doing. But when I try and pull it, the connective tissues that are adapted into that area, they're resisting me trying to pull it in an anterior direction. So it's a clinical observation, very readily palpable here. So yes, you can go through jeans, go through slacks. If you can hoik up the clothing out of the way, when you're first learning, it just helps with your palpation abilities there.
So how is it?
But how do you correct that?
And you correct that. It's tending to go this way, so you move in the direction of resistance, and you keep mobilizing it until it will move freely in that direction. Then in Simon's case, although I see you have orthotic devices in your shoes, you're wanting to help the body then function within that area to stop it from going to the end range. So what's happening is weight bearing, legs going to, and it's functioning in its end range position, and then everything is adapting. So if we can mobilize, get the area freed up, and then control the mechanics of the leg to keep it in a better position. Probably have to get you into an exercise program because I see you're really slack and lazy about looking after yourself. So, those kind of things as part of your patient management program. Yeah, of course. Diplomacy might be another thing that's worth remembering. So this is what it looks like with this technique here, and then the other option, we typically work with our clients in a prone position, but it's the same mechanics. Flexing the knee, grabbing hold of the fibula, and then gliding anterior and posteriorly. So generally, if you were lying down here, just have the knee, let the leg rest on my leg, holds it in a flexed position, everything's stabilized against the table, gets knee. Now I can just isolate that joint. We don't have the ability to practice the prone method, so just go to the supine version, flex the knee, and see if you can get the fibula head moving. Both sides, and grab a couple of different legs to see if you can feel different levels of resistance. Or
Are you able to do this on yourself?
I suppose. Oh, actually, no, shoes off, keep socks on. Okay, so these are the two mobilization techniques. If you were going to put some tangible action steps from this session, when you're doing your traditional biomechanical examination, whether it be range of motion testing or any other physical techniques that you do in your assessment, just include the fibula, particularly if your clients are complaining of perineal or lateral compartment or gastroenterochilies type of complaints. And just check, does it move, does it not move? If it doesn't move, just work on it for 3 repetitions or 6 repetitions. If things don't move, then a really good way is to encourage them to do that a little more enthusiastically. And that's where a manipulative technique comes into play. So what you'll see here is, in the prone position, we can actually just flex the knee, and with the fibula head sitting on my metacarpal joint, as you flex the knee, it literally forces the fibula in an anterior direction. So it's a very efficient way to be able to make that. Oops. Okay. Great. And this is kind of what it looks like in the overall technique. We don't have the time to go through this one for a practical perspective. But Simon, if I just get you to climb on, it's your left side, isn't it? So head up that end. Right. Beautiful. You just let yourself rest there. Oh, looks like the mobilisations work pretty well. That's actually sitting quite fine. So, my metacarpal joint, I'm just going to rest that against the fibula head, and then I'm going to flex the knee over the top, and then
Did that hurt?
good. Not really, it's a bit of pressure on the hand. Wonderful. Simon, give me 5. Thank you very much. Okay, just before we go, quick question from anyone? No. Thank you very much. Hope you have